Good evening. Good evening. Thank you all for joining us today for the 7th Listen, Connect, Participate as we discuss maternal infant mortality in the state of Indiana. My name is Rima Shahid, and I am the Executive Director of Women for Change. Women for Change is a grassroots, nonpartisan organization, and our mission is to educate, equip, and mobilize Hoosiers to create positive change. We are so grateful that you're spending today's beautiful summer evening with us today. Thank you. Just shows how important today's conversation is. We're also very grateful to our esteemed guest of panelists for joining us this evening. And as always, our programs are not possible without your engagement and your support. If possible, please make a $15 donation today to help us sustain programs like today's. We will also allow time at the end for you to ask questions. Please keep your mics off and cameras off during the program. At the end, you will be given a time to ask questions. We also like you to remember that Women for Change was founded in part on civility. So please keep your questions civil and productive. With that, I'm going to kick it over to my good friend, Dr. Velda Miller, who will moderate today's conversation. Thank you.
Hi, everyone, and thank you, Rima. I am delighted to serve as your moderator for this evening, but I'm even more thrilled to be on the panel with so many very, very credentialed, impressive, and do something panelists. They are about change. I want to thank Women for Change for continuing to focus on issues that are important to and affect women. So thank you, and please continue. We are about change. I'd like to review the format for our session this evening. I will ask each of the panelists to say who they are, what they do, and why they think this is an important issue. Why this topic now, in light of all of the other things that have happened to us in 2020 and 2021 so far, why this one has grabbed your attention or is a focus of your work. We will follow that after they introduce themselves and respond to that question. We will have questions for each of them. I'm hoping that they are questions that you would ask and things that we need to know. And we'll focus on what are we really talking about, what's normal, what can be done to prevent some of the maternal deaths, what supports are in place, and why is it that Indiana has remained at the 46th point on ranking. So I'd like to invite my panelists, co-panelists to get ready, and I think we'll start with Dr. Box.
Hi, thank you, Dr. Miller. I'm Christina Box, and I am currently serving as the Health Commissioner for the state of Indiana. My time has been taken up quite a bit, as I'm sure Dr. Caine's has been with the COVID pandemic more recently. So it's nice for me to be able to talk about something that really is where my heart has been my whole life. I mean, I've been an obstetrician gynecologist for 35 years now. I think that the way a society treats and cares for their women and their children really speaks a lot to the society in general. And I've always believed that when you look at a state or a country's or even a county's infant mortality rate, a lot of times what you see there is kind of a window into the health of that particular group of individuals. And so we really do need to look at the state of Indiana, knowing that we've had one of the highest infant mortality rates in the nation for many, many years. Now we've made lots of progress there, and so I'm excited to be talking about some of that tonight. But it is truly my heart to help women and families grow and to bring babies into this world, because I have never seen a woman or family have a baby where they didn't want the best for that child and the best for their family as they grow. So thank you for having me tonight.
Thank you. Who's next? Is that Dr. Caine?
I'll unmute and I'll start my video.
There.
Hi. Thank you, Dr. Miller. And nice seeing our other prestigious panel members. I'm Dr. Virginia Caine, and I am the Director and Chief Medical Officer for the Marion County Health Department, which is essentially Indianapolis, Indiana. Indianapolis in the past had two distinctions. One of those distinctions was that we ranked #1 in the country for Black infant mortality, and recently have had some high profile cases related to maternal mortality. And so when we look at the one indicator that people look at that details what the pulse of a community's health, they look at infant mortality, but maternal morbidity is really catching everybody's attention recently. And on top of the coronavirus pandemic, can add additional stresses for that young pregnant mom out there trying to have a healthy baby. So I look forward to the dialogue and conversation we're going to have about these concerns for our pregnant moms and their babies.
Thank you. Thank you very much. And next we have, is it Representative Summers? Yes.
Hello. Hello, everybody. I'm State Representative Vanessa Summers. I represent the 99th House District. I am entering my 30th year in the Indiana General Assembly. I believe that every young child should have their mother. And in Indiana, we are losing mothers to simple things. And we have got to be about changing the things that we know we can change and doing some new things to make the numbers for women in Indiana go down. We are losing almost 100 women, whether they're African American or Caucasian, just from having a baby. And that's just unacceptable in 2021. Thank you.
Okay, thank you. And Dr. Lucia Guerra-Reyes. Did I do it right?
Awesome. Thank you. Hello, everybody. I am so honored to be with these wonderful, wonderful trailblazing women who are very much ensconced in the culture of Indiana. I'm bringing more of a, let's call it, cross-cultural perspective. I'm a Peruvian medical anthropologist. I am an associate professor in the School of Public Health in Indiana University, Bloomington. And my entry into this whole, the whole area of understanding and thinking about maternal health comes from my research in Peru and my research in Indiana. And I always remember when I was early in my graduate career reading a paper that called Infant and Maternal Mortality Bellwether Measures of Health Equity. And so when researchers from the US look at other parts of the world, they look at these and they say, well, this reflects either an equal society or a non-equal society. And so when I came to the US, it was really surprising for me and dismaying also when I came to Indiana to see that these measures were really, really harsh in terms of maternal deaths and infant deaths. And so I come to this thinking about, okay, so what do these measures mean in terms of how people are experiencing these health inequalities and what we can do from where we are, each of us, to actually promote health equity and reduce and make this a joyous occasion and not a somber occasion for a lot of birthing people. So thank you.
Thank you. Thank you all. And I have to say, Indiana can step forward, as Dr. Caine said, and thanks to Dr. Box for really changing the statistics for infant mortality. We are doing so much better, and we need to thank you again and again for all that you've done for that cause. I know someone reminded me that Woody Myers was really instrumental too. So we can give him kudos, but at this time today, at this session, we say thank you, Dr. Box.
Thanks, Dr. Miller. But remember, that's a lot of teams and a lot of counties across this entire state, boots on the ground making that happen. So I kudos to the state of Indiana working together to make this happen.
Thank you. Dr. Caine, would you would you please give us just, what are we talking about? When we talk about maternal mortality, what are we talking about? And what's the big deal?
Well, I think the main deal is, and there are two kind of causes of maternal mortality, and I believe Dr. Box can actually explain it a little bit better, Kristina, because she just went through a huge big review related to this and looking at the data for Indiana. So I'm going to pawn that question off to Kristina.
Yeah, so I think that what Dr. Caine is saying is that we have a couple different types of maternal mortality. One of them is pregnancy-associated deaths, meaning that the young lady died when she was pregnant or in that first year after the baby was born. And it could be from any cause. She could have been in a motor vehicle accident. She could have slipped on the ice and hit her head. It could be a substance use disorder overdose. Then there are pregnancy-related deaths, and that's a woman who dies during pregnancy or labor and delivery, or in that first year afterwards. But that's because she either had an exacerbation of an underlying condition. For instance, she had diabetes and went into renal failure, or she had lupus and had a severe hypertensive crisis, or she developed a pulmonary embolism and died. So it was an exacerbation of an underlying condition or a new condition that started directly related to pregnancy.
That was a good punt, Dr. Caine. I'm not going to let you get away with that.
I scare myself sometimes. So when she's talking about those pregnancy-related deaths, one of the most common causes that we see a lot of times may be related to strokes, cardiovascular disease like hypertension. We hear about this word preeclampsia that can occur, and we've seen cases of postpartum hemorrhage. But even in the case of Serena Williams, that famous tennis star, we can hear about, you can get a pulmonary embolism or that amniotic fluid embolism that can cause some huge problems. Now, I'm an infectious disease doc, so I look at those cases where it may be related to infection, where they may get a bacterial infection in their bloodstream, and it can cause them to go into septic shock and lower their blood pressure and impact the blood flow to all of their organs. But strokes, heart disease, and we have pregnant mothers that don't realize they have a congenital heart defect until they're pregnant because of the amount of extra fluid that's brought on board as a result of having that baby and that body weight that's led to the baby. So those blood clots, the possibility of a postpartum hemorrhage, or the possibility of a embolus, whether it's a pulmonary embolus or you can get an embolus in your lower extremities. There are a whole host of different causes that are preventable, especially if that blood pressure is up.
Okay, this is for anyone on the panel, and you've mentioned it. Both of you have mentioned this. What is preeclampsia? Isn't that something that should have been wiped out 1,000 years ago? Why are women still dying of eclampsia? What's the deal?
So I think that's a really good question, Dr. Miller, and that is still in the source of a lot of research, not just across the United States, but across the world. We do know that it is more common in women with certain underlying health conditions like diabetes and lupus and high blood pressure. We do know it's more common in African American women, and it can present in different ways. I mean, usually the individual shows elevated blood pressure and protein in their urine when we check their urine, but sometimes they can present very ill with what we call pulmonary edema, fluid on the lungs, or very, very low platelets. We just happen to check their blood count and find out their platelet count, which is what helps them to clot, is very, very low. So it is certainly a disease somewhat of mystery. It is not always evident immediately that that's what the individual has, but it's certainly something that we need to always put in the differential as we're ruling things out. And it also can present not just while the woman's pregnant or during her labor and delivery process, but it can present postpartum. Usually it'll be within that first 4 to 6 weeks, but we've seen it later than that at times. So it's just really critical that we are thinking about the fact that this woman either is pregnant or just had a pregnancy, and thinking preeclampsia all the time and ruling that out.
So one of the other things I think we want to think about is that this preeclampsia can involve not only the hypertension, but different organs of the body like the kidney and the liver. And some patients will complain about, wow, I may have a little change in my vision, blurred vision, or the lights may bother me. And then, of course, we all know about that morning sickness, okay, that people can have in terms of symptoms sometimes. But it's that they lose this protein out of their urine, okay? And they get this, what they call proteinuria. And this is where that fluid buildup, where you may have the swollen legs, or even your face may become kind of puffy and what have you. Along with that high blood pressure, now you can start to get severe headaches. And it can be a gradual thing with this preeclampsia, but sometimes, unfortunately, it's a sudden onset. And pregnant women can even get seizures if that blood pressure gets that high. And so just really concerned about that. So if you're having some pain unnecessarily that you haven't had before, or any new symptoms, don't wait. Contact your doctor, please.
Okay. Dr. Guerra-Reyes, would you help us put this in context? You've done studies of different countries and compared healthcare systems. What's different? What's happening in the United States that is causing some of these challenges?
Interesting that you say that, because one of the main things that really struck me is how much is not different. I mean, health systems are different, right? One of the things that is different in Peru, which is where I'm from and where I've done a lot of my research, is that there is universal health insurance for people who are low income. So indigenous women who I did research with, or in Peru, in 2 different parts of my country, have free access to a free birth in the clinic should they want it. The struggles are different. There are different kinds of struggles. There's struggles of cultural competence, there's struggles of racism, however, and microaggression, and the medical model of care, which very often neglects women as humans rather than rights-bearing individuals, where they express what is happening with their bodies and are not really listened to, and where things like dismissing their concerns because they are indigenous are things that I have read about and that people have told me that have happened to them here in the United States. There's a really poignant book by Dr. Dana Aine Davis, another anthropologist, called Reproductive Injustice. And she collects a lot of the things. When I read that book, I was like, well, this is a lot of what Indigenous women have told me about what was happening to them when they were in a clinic, and how they were dismissed because they are Indigenous. And race, ethnicity function in different ways in other countries than they work in the US. But the dismissal, the racism, the bias remain and put those women's and those children's lives at risk in the same ways. And the not listening part is something that really, really comes out to me. And especially, and in my research, I interview not only women or parents, but I also interview doctors and policymakers. And I think that nobody is seeking out to be a biased person, right? This is not how it goes. The bias is very deeply entrenched in how we perceive others, and especially others that are different from us. And there is a very sort of a tension between the us and the other, that this racism, bias, and microaggression and macroaggression really cannot, seems to be prevalent both in the US and in other countries as well. And so seeing the person, the birthing person, as a rights-bearing person, rather than a risk, which is a lot of the ways in which sometimes clinical people approach birthing people. It's like, oh, this is a risky person. Instead of seeing them as a rights-bearing person, they see them as a risk-bearing person. And it is those decisions based on risk and how we clinicians make decisions for others because they think those others cannot make decisions for themselves, are things that are really very similar in both of those contexts.
Thank you. Representative Summers, you have the envious position of being in the room with a lot of men talking about policy. And how, I will come back to you many times on this, but how do we communicate this issue to men creating policy?
I have tried everything. And what I found, and what we're trying now, is to rope their wives in. You know, that was the last thing. But you know, we are almost more in the state. We're almost more women in the 100 in the House than it is men. So if we keep going like this, we will be able to do what we want to do sooner or later. But actually, if you show them the facts and appeal to them, actually their daughters, their wives, some of the things that their mother had to go through. And then a lot of times, well, not the men at the State House, but around the community, maybe other men see that because they also have a hard time with access to care. Okay. So that's what kind of happens in the community. They always, you know, African American men have also, a lot of times their pain is criminalized. So they also have a hard time accessing services. What I'm finding is we have people that cannot get from point A to point B to take care of themselves. You know, they may have they may live on one side of town, but they have to make it to the other side of town to access a doctor. So how do we fix that? You know, what are the things, the plans that we should do? And a lot of that is community driven. What can community people do? So identifying those community organizations. And I really believe right now that there just needs to be education. And I had said this to you all. I would love to come up with something that we could do to talk to women about maternal health, but not scare them. That.
I'm sorry, go ahead.
So that is that's where I'm at. I'm on the thinking end of how do we get them to understand that they need to take care of themselves, or they may not be around for their children, but not scare them into taking care of themselves. Make it a choice.
Very much, yes. So that raises the question of how do I know what's normal in pregnancy and what's not normal, and what do I need to look for? If this is part of education, so if I'm pregnant, I'm not, but if I were pregnant, what would the things I can expect?
Well, I think that's a great question, Dr. Miller, because even when I became pregnant the first time, and I had been through my residency and, had been doing this for a while, I, had that pain on my right side when I was about 20 weeks along, and it hurt worse with movement. And you probably, anybody that's been pregnant's had it. It's called a round ligament pain. And I just went to my doctor and I was convinced I had an appendicitis. She goes, no, it's round ligament pain. And I'm like, but no, it hurts too much. And she's like, yeah, that's what round ligament pain feels like. So what I'm trying to say is that even as professionals, we don't always know. And that's why we need to be connected to someone whom we trust, who listens to us. And I mean, not just listens, but actively listens, repeats back to us what we're saying to them, so that we know that they actually hear us and that they actually understand our concern or our problem. And then, quite honestly, even as a practitioner, there were times when I would be pretty confident about what something was, but I would say, but you know what, if this does not improve with doing X, Y, or Z, or you feel like this is getting worse, or you see any of these other signs or symptoms show up, that's where I want you to call me back right away. And they know how to reach us 24/7. I think education is really, really good. I think when women have books to read about where they are and what's going along, when they are oftentimes together in classes. I love prenatal classes where women get together and discuss things, because to be honest with you, they will share more freely there sometimes than they will even in my office, about what's going on and what their concerns are.
There is a example of some things that are happening in other states that are not necessarily happening in Indiana. And one of the things that I have would like to go in and see somewhere is a centering group where, like pregnant people, same due dates, stay to, have their appointments together, have some sort of group together, which helps them help each other. And I think that we are going to have to start trying to do some things like that in Indiana. They're doing things, they're doing things in some places in Indiana also they're doing, but we need to know.
Yeah, Lake County Representative Summers has a very great centering pregnancy, and centering pregnancy itself is a particular program which is kind of more expensive, and that's why a lot of people can't afford that. But to be honest with you, it's really about having someone there who is knowledgeable and getting together a group of women that are around the same place in their pregnancy. And then the great thing about that is that even continues post-pregnancy through that first year or two of the baby's life, because now they're connected with other women who are experiencing similar issues with newborn babies and babies as they grow and their breastfeeding and other things that come up as natural questions at that time.
And also there's, of course, the doula phenomenon is something that we need to grow in Indiana, where there's a woman that helps you through your pregnancy and a year afterwards. So those are the example of things that we need to move and make sure is happening in the state of Indiana to help women. I think whatever we could do to help women figure this out, all of it, doula, centering, anything else we can think of, I think we should figure out a way to get it done.
I agree. Thank you. And we thank you and Senator Jean Brewer for pushing the doula presence in the community, and the fact that it makes such a difference for women of color to have that doula. And Dr. Guerra-Reyes, tell me, in the Latino community, there's significant support. Am I correct? Or what has your finding been?
So I think that you mean postpartum support or just general support?
General, through the pregnancy and postpartum.
That is difficult. I mean, I will just say that when we talk about Latinx communities in any place in the United States, but very especially in Indiana, we're talking about a very diverse population, right? We're talking about people who are from different parts of the world that speak the same language, but are not necessarily all from the same country. And so things vary in different realities. But what I've seen in my research here in Indiana is that really the same thing that we talk about when we talk about non-Latina people, when they have support, especially you can have apps and other sort of forms of external support, and you go to the doctor during prenatal care, if you are engaged in prenatal care, during labor, but postpartum is where everything basically falls off a cliff, right? The baby's born, and then all of a sudden you're not seeing anybody. And you're isolated for the most part. What I've seen with Latinx communities is that if anything, they have less support if they are one, undocumented, and therefore cannot access support systems that are thought of from the government perspective to support people who don't have insurance or other things. There's a lot of fear because of potential using of something. For example, if you use WIC, if that is going to count against you when you want to regularize your papers. And so that was a thing that the prior federal administration had put forward, the public charge rule. And there's less support in community because a lot of people do not have their families with them. And so immigrants, and this is a different, so you have different types of Latinx peoples. You have those that are several generations in Indiana and others that are newly arrived. And the ones that are newly arrived tend to be young people who do not have their support systems here, and their support systems are rather thin rather than thick or dense, which is what we would like to see. In research, what I've seen is that young women need to drop out of the labor force. They stop working to take care of children, or they have somebody who has stopped working to take care of their children. So a grandmother or somebody who is an older sister sometimes. But overall, what we see is that postpartum, I think, is the more difficult period because a lot of things just fall off the cliff for everybody. Yes. Not only for Latinx women, for Black women, for white women. And the isolation and the lack of connection with others is something that I think is very difficult for a lot of people.
You each have raised issues that we could explore on and on and on. The folk that are participating online are asking questions about doula and the most, where can they get more information and what's current about doulas, and preeclampsia. In this day and age, why do we have so many with preeclampsia when we have sophisticated monitoring, etc.? So I'm tempted to just open it up, but here's where I'll start. Dr. Caine.
Yes.
We just started talking about supports and things that are supportive and important during pregnancy and after. One, during COVID, people were not, or partners or support folk were not allowed in the labor and delivery room. Tell us what you think the impact of that is and on healthy, fearless, enjoyable, if possible, labor and delivery.
Well, it's just what can I, pregnancy it's a 9 months experience. And that person who's your significant other, if they've been involved in that care, it's almost like post-traumatic stress disorder to have that person go into a hospital and you're not there for that person. And that person having that delivery, knowing that they don't have that same support while they're doing having their baby. So it's like they're alone, and the people who are most important to them are not there to share. Probably one of the most wonderful experiences a mother will ever have in their lifetime, or even a father or a significant other having that experience with their child being born. So, and we know just from the pandemic, COVID alone, the stress and the anxieties that are related during this hospital atmosphere. Am I going into a hospital where there may be a lot of COVID-19 cases? Could I possibly be at high risk for getting an infection? Or it's so packed in that hospital system, am I going to get the kind of attention I need, the monitoring and the surveillance? Because, a lot of our healthcare workers, they get kind of burnt out with all this intensive load and what's going on. So I think it will have some major implications for these pregnant mothers, and I think for months to come, and it may precipitate at a higher risk postpartum depression that we don't always pick up early after mom has delivered her baby. And so we're seeing an increase definitely in anxiety, depression, suicide. And so just so many things that are complicating this issue. And then how healthy is mom? Because of food insecurity, difficult people losing their jobs. And so how healthy has she been? And then a lot of doctor's offices were closed. Even if she wanted to get help, she had to try to figure out the technology of how to do telehealth. And I can tell you, telehealth is wonderful, but it's not the same thing when you're having a baby. You want to see that nurse practitioner or physician or whatever healthcare professional. You want to see them and be able to ask those questions kind of face to face in person. And so, wow, I'm taking all these herbs and supplements, is it okay for me to still take it? Okay. Your significant other's pushing you out the way to say, how long can you have sex during your pregnancy? So, there's just a lot that's involved here in this process. And there's so many answers you need to know to have a healthy baby.
Thank you. And you've raised the issue of preparing questions and having someone with you, and the impact of not having that postpartum can lead to serious challenges. I'm just rolling over with lots of questions. So, Dr. Box, I have a 3-part question for you.
Okay, better write this down then.
Talk to us, please, in terms of supportive systems that the Department of Health has initiated about navigators. What is that? And
so, yeah, go ahead.
Second, what are the hospitals doing to address the issue of complications and anticipate or minimizing maternal death? And then third, what about these food deserts? If we want pregnant moms to be healthy, what are we doing about that? So there you go.
all great questions, all great questions. So first of all, I think what everybody's been saying here is we need support for women, and it may need to be support that's outside of that clinical setting, right? As an obstetrician gynecologist, I like to believe that what I do in my office with that patient is what's going to make a difference. But realistically speaking, what we know is that about 80% of a woman or an individual's health has to do with where they live and their work and their education and their ability to have a job, to keep their lights turned on, to have access to good care and to healthy foods. So all of that really, really impacts it. So the concept of the OB Navigator, which is now known as My Healthy Baby program, was just that we had, number one, in the state of Indiana, lots of women that don't get care in their first trimester. And, by the time you're 12 weeks, that baby is completely formed. Every single organ system in the baby is formed. And after that, it just grows and develops more. So we want to see, somebody said to me one time, Dr. Box, do you really want to see them in the first trimester? Because sometimes you can't even hear the heartbeat yet. And I'm like, no, actually, I'd like to see them before they conceive. I'd like to talk to them about their habits. Do they smoke? Do they drink? Do they use other substances? I'd like to know what their weight is. I'd like to know what their diet is like. I want to know, do they drink excessive amounts of caffeine? Do they have high blood pressure? See, that's part of the problem with preeclampsia, is that if you don't see someone in the first trimester, you don't know what her first trimester blood pressure was. In the second trimester, a pregnant woman's blood pressure automatically drops. It gets lower. And then in the third trimester, it goes up. So the only way I know that's preeclampsia in the third trimester, when that blood pressure is up, or pregnancy-induced hypertension, is to be able to compare it to that first trimester blood pressure or a non-pregnant blood pressure. So really that concept of how can we, as soon as we know a woman's pregnant, she showed up in the emergency room, she got a pregnancy test done, she had bleeding and got an ultrasound done, how do we make sure that we proactively reach out to her and offer her the ability not only to get connected to prenatal care in the location that works best for her and where she wants to deliver, but also to someone who can support her through the entire pregnancy and for that first year of the baby's life afterwards, and connect her to resources that she may not know are available to her to help her. I remember seeing specifically a substance use disorder patient. She told me one time, she goes, I'm going to get evicted from my house. I can't make my appointment today. And I'm like, well, why are you getting evicted from your house? You have a job. It's on the bus line. You told me you could take your kids to daycare on the same bus line. And she's like, because I don't have a mower. And I have about, the size of my kitchen table worth of grass that I need to be able to mow. And they're going to evict me because I'm not mowing it. And I was like, it was a simple thing for me to reach out and help find someone to either mow that grass for her or to get her a mower so that she had that capability. But those are the kinds of things that can make a huge difference in a pregnancy and a woman's life. So the OB Navigator is there to navigate all of those resources. Then you ask about what are we doing in the hospital systems, and I think that's really, really important. A lot of this is thanks to Representative Summers and all of her colleagues, but we have instituted levels of care, which was voted through. It was part of the governor's agenda in 2018. And that means making sure that every woman that has risk factors or her baby that may have risk factors delivers at a facility that is capable, has the personnel and the equipment and all the technology needed to be able to take the best care of that woman and her child. And so the American Academy of Pediatrics has shown quite clearly over the past 20 years or so that these levels of care established for babies, newborn babies that have complications, if you make sure they deliver at the appropriate hospital, that they will have less morbidity and mortality. They'll do better. So the same thing is now happening also with maternal care, in that we are actually going around and surveying hospitals for their levels of care. And if they want to be a certain level, then they have to have a certain amount of personnel that are there, the right respiratory therapist, the right type of imaging systems, the right type of maternal fetal medicine specialist, et cetera. The other thing we're doing is looking very carefully at what women die from, like hypertensive crisis, like hemorrhage postpartum, and making sure that we implement what we call AIM bundles, which is the Alliance for Maternal Health, which is through the American College of OBGYN. And that is to make sure that every hospital system is equipped with an immediate rundown of What needs to happen if somebody presents with excessively high blood pressure? What needs to happen immediately if somebody is bleeding or hemorrhaging out? And that has been shown to decrease maternal morbidity and mortality. So those are just a few of the things that are happening here in the state that I can say I'm just really proud of the fact that we have been able to engage so many hospitals across the state. And we only have 85 delivering hospitals. We have quite a number of counties that don't have a delivering hospital. So then we run into this problem that we don't have, they're OB deserts, maternity deserts. And when you don't have care for the pregnant woman, you oftentimes don't have care for things like contraception and well women's health, which is also really important. I've been talking a lot, so I'll pause for a minute.
So then I think that's when then community organizations need to come in and be empowered to help people in the community. And I think that's part of some of the things that could probably just be a little bit better in Indiana. But I'm prejudiced because I work for one of our co-sponsors, the Indiana Minority Health Coalition, and we are really trying to do the work to help minorities, and especially women during this time. But I still think that when Dr. Box talked about the mother that doesn't come in that first trimester, I think that's probably some of the people that we really should be going after to make sure that they get on the right path, because they can really be on the wrong path, Dr. Miller. That's all I got.
Now, Dr. Miller, because I'm a health officer, we gotta talk about some tips for the pregnant women, okay?
Yes.
About what they should be doing in their trimester. And for Black women, for those who are not natural, who may get their hair straightened or highlighted, do you realize that chemical hair straightening probably should be avoided in pregnancy if your hair relaxer contains something called formaldehyde? And a lot of people may not realize that, but it's a chemical that can harm their fetus. So you can't just use any hair relaxer while you are pregnant, or you may be causing a birth defect in your baby and not be wearing it because you're trying to look good during your pregnancy. But the other things, and I know we know it, but you just can't drink any alcohol. Harmful effects to the fetus. You can't smoke or vape if you're a young teenager. That's not going to happen. And you got to get that exercise at least 30 minutes 3 times a week, if at all possible. I think that's just so critical. But and you need to drink plenty of water. And now some people talk about, I got to have my caffeine, my coffee. Well, you could probably have 1 cup of coffee a day. Is that, Christine? Is that about right?
Yep.
But you got to look
6 to 8 ounces. Mm-hmm.
Yes. So, but you got to be really careful about that. Now, I love tuna. I'm a sushi person, and I'll eat it all day and all night and every day of the week. But you have to be very careful about eating a lot of fish that contains a lot of mercury as a pregnant mother. So, if you like swordfish, king mackerel, orange roughy, and I can bake an orange roughy like nobody's business. But you do have to limit white tuna to no more than 6 ounces a week. Definitely no unpasteurized milk, please. Okay. And then I know people love their eggs kind of over and easy.
Over easy. Mm-hmm.
So really, you need to eat no raw and uncooked eggs if you don't mind, or any seafood. And I got 3 lovely cats, beautiful. I got 2 adult cats and 1 kitten. But as a pregnant mother, you're not supposed to change cat litters. You can't do it. Be very careful, because there's a parasite infection called toxoplasmosis that you may be at risk for. The same condition that Arthur Ashe died, the famous tennis player. So those are just a few of my chips, if you can avoid those, I think that's kind of helpful. And then I also think, I know ladies might love those hot tubs, but if you're fortunate enough to have it, that temperature is too high for you to be getting in that hot tub, okay? And then but you can take a bath. That's not a problem, I believe. Is that right, Kristina?
No problem there.
Okay. And then I just have to say that probably for me, the most important thing in this era right now is getting your vaccine for COVID-19 and the other necessary vaccines that you need. Because we know that pregnant mothers with COVID are at higher risk for greater complications than if they have been vaccinated for COVID and can prevent that infection. So, but that's something that you should talk to personally and be a personal decision between you and your healthcare provider, and let her talk about him talk about the safety benefits versus long-term complications, because you're at a much higher risk for greater risk being pregnant than if you were not at risk. So, and oh my goodness, that breastfeeding, okay? That's so important, that breastfeeding. And we know that mother can pass those maternal antibodies to their babies through breastfeeding to help protect that baby and provide natural immunity for a number of months. And breastfeeding cuts down on obesity in the future. It just has so many wonderful benefits besides cutting down on infections. And so really strongly consider making sure that moms get those resources for breastfeeding. And they need that iron, ladies. Iron deficiency anemia, folic acid, vitamin D, okay, even vitamin B. So, we need those supplements of those vitamins. And if women get in at the late trimester, they don't get the full benefit of taking those vitamins. So we've got to figure out a way that in their first trimester, because they're not getting in first trimester, a lot of our African Americans and our Latino X populations, what can we do to start those vitamins, even though they're coming in late?
A really good point, Jenny. Just taking prenatal vitamins, even when you're not planning on being pregnant, even when you're not pregnant, is really good, because we know how many unplanned pregnancies happen, and that extra folate decreases something called neural tube defects, which is also called spina bifida, which is a more common birth defect in babies. So really good that a lot of people feel like all women of childbearing age should be using a prenatal vitamin every day.
Can I jump in just real quick? I want to sort of highlight a couple of things that I heard you say that I think are really important. And one is we need to think about maternal health in a continuum, right? This is the health of women or of uterine bearing people, people who have uteruses. So that means that we need to think about contraception and access to birth control, and having the possibility for those who want to have children to have them, and for those who don't want to have children to not have them, through having free access to birth control. And that would go a long way to allaying some of those fears, especially when we think about the health issues, the individual health issues that people have coming into pregnancy, or not knowing that they're pregnant and going to prenatal care. And the other thing that I was thinking about when you were talking was there are experiences of how other countries around the world have managed what we are calling now OB deserts, which is basically how other countries manage rural areas that have no clinical personnel. And throughout the world, Latin America, in Africa, in India, the community health worker has been that person. Has been the person that has filled in the gap, like like Representative Summers is saying. So, but we need to support legislation, we need to support policy, we need to support requirements, something that will make those community health workers have the ability to connect women, to fill those gaps, but also to fulfill their own lives, right? And have a livable wage. And that's where, for example, the Medicaid reimbursement of doulas comes in, which would be really cool if that happened in Indiana, because I think that it has happened at least in one place. And so these are sort of things that we don't need to reinvent the wheel. Things have been done that work. And I think that that is something that we need to sort of think about and see how they can be adapted and put forth in this context in Indiana.
So Representative Summers and the legislators have already been supporting that. They may not realize it, but the money that we've got for OB Navigator, we also are addressing our OB deserts by working with hospital systems to hire either nurse midwives or advanced practice nurses or PAs to go into the counties where there are no obstetrical providers and actually see patients closer to home and provide care there. We can't do the deliveries there because there's not the ability with a hospital, but at least we can deliver the care closer to home so that women do have that access and do have that support.
Thank you. Thank you all. There are more questions, so I'm going to throw this one out, and somebody catch it, please. Actually, it's two-part. Somebody catch it. We've not explicitly talked about disparities and why African-American women, Black women die 2.5, 3 times 4 at a higher rate than whites. And Dr. Guerra-Reyes, you mentioned the issue, the hot button issue, implicit bias and racism. And on the third part, I'd like to throw out, I do 3-part questions all the time. Somebody talked to me about weathering. What does that mean and what's the impact? So I'm asking, let's really get into the disparity issue. Let's talk about this thing called bias and what it means for providers dealing with patients because it can be deadly, and what is weathering. And when we can have answers on that, I'd like to open it up to our participants. Apparently there are tons of great questions. So I throw that out to you guys. Somebody catch it, please.
I can try with the weathering. I'll take the last one first. What I understand weathering to be is what happens to a person from external things that happen in your life. So if you are someone below the poverty level and you don't have access to good food, good water, doctors, you live in an area where there's always danger, or you could be in a domestic violence situation, you are always under pressure, weathers your body and makes you internally older than you may be by age. So external issues affect you internally. Did I say that right, doctors?
Good.
I would agree with you.
Okay, that's what I know about weathering.
There's also the fact of something that also was thought of by a Black woman, and a Black theorist, which is the idea of intersectionality, right? So you are at the intersections of environment and your own body and how the society, structures of power in society you are. And so you live as a body in all of these different intersections that affect your health in different ways. And that for some groups of people that are more sort of ostracized or diminished in society, these effects are harsher than for others. So it's the loss, the ones that do not suffer weathering have privilege. The ones that do suffer weathering do not have privilege.
Yes.
Well, that's often the case. What we know is the research by Dr. Geronimus on weathering says that she adds to what each of you have said, and it really is the deterioration of health because of the cumulative impact of all of the stressors that many African-American women face, and I'm particularly concerned about that. So it has scientifically been shown that it affects the neurological systems of the body, and why there's more chronic health issues in people of color, and particularly Black women. So weathering is a good concept for us to keep in mind, because you are often daily faced with things that remind you that you're not welcomed or you're not included.
So one other thing I want to just talk about physiologically, so that we know, especially if I talk about Black women, that because of the stress that they face, it increases the amount of steroids, cortisol, in your body. And as a result of that cortisol, there's an increase in inflammation, and it even impacts the fetus related to that. So we have our babies lower birth weight babies. We have our babies more likely to be born early, preterm, which increases and has a higher rate of outcome. So, and I say this, that people don't understand a Black pregnant woman versus a white pregnant woman will have implicit biases going along as a difference between the two. And that implicit bias that occurs or happens, because you never know when it's going to happen or pop up, it keeps you at a higher stress level, a higher level of those steroids, and that over a chronic period of time can have an impact on you. Now, and I say this because I'm trying to give an example. And I guess the best example I will give is when I was growing up, I went to an all-Black high school, but I was going to go away to a white college. And so my mother wanted me to have the experience of what it was like. So for summer, I went to an all-white school, but I was the only Black person in the classroom. But let's reverse this. And if you had an all-Black classroom and you had a white student come in there and they're the only person in there coming in that room, would there be some increased anxiety a little bit, or just a little uncomfortableness because they're the only ones there? A white student that's in an all-Black school, an all-Black college. I went to Wyoming for a big foundation, Robert Wood Johnson Foundation conference. And I happened to be with my good friend, Miss Betty Wilson. She was the former executive director of the Health Foundation of Greater Indianapolis. And we were in Wyoming, and we were downtown, and we were just, window shopping before our meeting started. And I kept saying to Betty, I said, I just can't figure it out. Something that's different about this place. And she's looking at me like I'm crazy. She said, what's crazy is you don't see no Black folks at all in this town. And you're finally getting it. And I looked around and she was right. I just couldn't put my fingers on it. So there are a lot of stresses that are not always visible to the eye that can have impacts on us. And even if it doesn't happen to ourselves, we may see it happen to other women of color or other men of color, like the George Floyd. That in some level bothers us considerably, because that could be my brother, or that could be my cousin, or that could happen to me. And I've been stopped by law enforcement and was not very pleasant to me here in the city. And I've had my nephew stopped, I think from profiling, honestly. And so those are the kind of things that will happen to me, but may not happen to my white colleagues or my white friends, but I know that it can happen. Actually, I've been stopped twice, to be honest, okay? I just thought about that. But it was all good. I got no tickets, so It was just a case of they thought I had stolen my own car, which I reported because my car got stolen, but it had been returned to me. So they thought I was a criminal stealing my car, though I was dressed in a nice suit like this, looking clean. You know, I was going to get video at the Motor Speedway, but I was kind of treated like I was a real criminal. So they had me get out of the car, stand over the car, kind of stuff. And because I asked, you know, was there something wrong, officer? But never got a reply. Wouldn't talk to me, wouldn't respond to me for a long time. And I said, ooh, I think he's not having a good day today. I better keep my mouth shut and just do what he says. But it's inevitable that I think, and maybe this could also be a gender thing, that I wondered if I was a white male looking very prosperous in the car, and would he have been asked to step outside the car and treated the same way? And I say that to say that we've gotten to the stage that I have that thought process. So something's wrong that I even have that thought process. And so those kind of stresses can have a negative impact on pregnant mothers, especially when it's coupled with this COVID-19 pandemic, where we've lost a lot of our loved ones. Folks, there's no way they should have died healthy. This epidemic shouldn't have happened like this. It just came out of nowhere. And so all those unknowns really creates an environment that sometimes we need to figure out a way how to give that mental health support in these mental health challenges.
Got it. And I do want to say a special thanks to you, Dr. Caine and Dr. Box, because you were so attentive to the COVID crisis. And every day, I know you guys were putting your heads together.
Yeah, Dr. Box, she be calling me at 1:30 in the morning now. So
Don't be telling on me.
Okay.
The only time I can't call her is 11:30.
Yeah, she's interfering with my Perry Mason time from 10:30 to 12:30 in the morning, okay?
I'd like to open up to questions from the group, and I'd like for all of us to think about or consider what are the little things that anybody could do to help a mom that is pregnant stay healthy, or take the burden off of her, or give her a compliment, or help her to have a pregnancy that and a delivery that she is valued and listened to. Just an aside, when I was pregnant, I had a favorite aunt who helped me make a little black dress for pregnancy. I felt so pretty. I felt so good, but the little help she gave me and the compliment that I got afterwards meant so much. That's a very little thing, but I'm asking, and in our project of Not One More, we are encouraging folk to consider your aunt, your cousin, your uncle, the man in your life, the woman in your life, little things that can make a difference and help us deal with the prevention of maternal mortality. I'd like to open it up, and Haley, if you can, help me please screen the questions. What can we do to reduce the stigma?
Stigma of substance use disorder, or?
No, I think is this from the Indiana Maternal Mortality Report suggests that providers, is that the one you're reading?
Yes, the Indiana
That providers should do
report.
more to reduce stigma and increase support for new moms in regards to their mental health.
It's a great question. And I think the one thing that I haven't had a chance to say that I really want to say, and that is the first step in preventing maternal mortality is an understanding who's dying in our state when they're pregnant or in that first year afterwards, where they're dying. Is it our urban, our rural settings, and understanding what they're dying from. And that's the great thing that Representative Summers and the rest of the legislators, when they voted through the Maternal Mortality Review Committee, we are now able to go through and actually critically review every single maternal death, not just the clinical records, but the social records, the emotional records, the family situations. And when we looked at those, then they come out with 170 different unique factors that they think, if they were different, could potentially have changed or saved that individual's lives. We had our two biggest contributors to maternal death were mental health factors and substance use disorder. Almost 40% of our women died of substance use disorder and mental health. Now, one of the things that we've done, and I'm so happy that Dr. Sullivan has done this, is we will now have a year's maternity coverage for women after they deliver. And this, unfortunately, doesn't help our undocumented women, which is still heartbreaking situation for me. But we can work to find areas where people can still get care. But the important thing is you don't just continue with your postpartum care with your obstetrician, but that means your care for your substance use disorder, your care for your mental health disorders, whatever that is, continues. And that support continues through that very most critical time, which is immediately, after delivery for that first 6 to 9 months. The other thing is that Black women have a higher incidence of something that we call cardiomyopathy, which is where the heart just doesn't function well all of a sudden after delivery. Oftentimes that doesn't show up in the first 42 days postpartum. So it may be something that develops down the line. And by the fact that we're continuing this coverage, women are more likely to come in and say, I'm short of breath, I'm fatigued, I just don't have any energy anymore, I can't do anything, and see their physician, oftentimes their obstetrician that took care of them if they had a good relationship with them.
Thank you. That's great. We have another question. How can those of us in the community, just regular folk, not docs, support improving doctor-patient relationships?
Repeat that question one more time.
How can just regular folk in the community, the aunties, the uncles, the cousins, how can we in the community support improving doctor-patient relationships so that questions are asked without fear or hesitancy, so that they're listened to? How do we do that?
So I think one thing I've always tried to emphasize that if you are a patient, it's sometimes nice to have a patient advocate from your side, either a personal friend, a family member, or a significant other.
Or a doula.
Or especially a doula who is trained to do stress reducing tips with their person that they're helping, and know that person well, can sometimes be that support if you're allowed to have two people in the room, which usually they should be, to help. You may forget a question, or sometimes you may have a provider that may not realize they're talking down to you and not with you. And so be able to ask those questions in a manner for that person to answer your questions where they're not rushed. You can just tell sometimes when I've had to see my provider, they're ready to get out the door just as they come in. And I know this is going to be a quick process, and I know they may be overwhelmed with patients, but I want my good 15 minutes of your time and your attention to me. But it's the same with the provider. I want to see a patient and you're on your cell phone talking to them, or you're looking at your text messages talking to them. But we're going to have to do a better job of communications between provider and patient. There's no hands down about it. Our medical curriculum has to be changed in our medical schools, our nursing schools, our other healthcare professional schools. 1 or 2 hours of training related to implicit bias does not make you culturally competent. So we're going to have way more case vignettes where it is really clear, how you're talking to me, you don't think you're insulting to me, but you're very insulting to me. And you don't even know it. And you wonder why I'm not being compliant with your recommendations and why I don't even come back to you.
That's right.
And so it's those things that they don't even know that they're being, and they honestly really don't even know they're being insulted because they've been brought up that way for years and don't recognize it. So our educational institutions, our hospital care systems have to have a better curriculum, longer hours, ongoing and persistent to address this. And even if the person doesn't get it, that healthcare system or that provider's office need to figure out a way how you can just say things in a very nice manner or way so that the provider understands that they may be talking to you and you don't get it, especially if they try to give you some mumbo jumbo stuff that they know you're not going to get, but they can get you out of that office quicker, okay? So you give it to me in layman's terms so I can understand that. And we can have a honest, transparent dialogue.
Okay.
I would also say just real quick that we have to normalize that people who are going into a clinic or who are looking at a provider and seeing a provider have rights, and they have the right to ask. And providers have the responsibility to listen and answer. And this goes back to thinking about people who are coming to your clinic or to your practice as a rights-bearing person, as a person who has questions and doubts, and opening the space to do this. And I think that thinking about medical education, as Dr. Caine was saying, in terms of thinking about how complex issues of social determinants of health that somebody mentioned in the chat are related to how we can understand the people who are in front of us as fellow humans and not just as a potential statistic.
And Dr. Brewer, let me just add this point, and especially thanks for the person also in the chat about the social determinants. We know that medical care improves health outcomes by 20%, 20%. But when you add and address the social determinants around medical care, you improve your health outcomes by 50%. So we really have to change the paradigm of how we provide medical education and what the healthcare professionals are responsible for. You just can't do that traditional, all I want to hear is just your medical disorder and cut out everything else. It's not good medical care, and that's no longer going to wash anymore. But they have to be taught about what the role and how social determinants play with their patients, okay? And understand the perspective of that patient in terms of how they're providing professional recommendations to them.
We're getting close to the end time, and I still have several more questions and several more thoughts. This is the $60,000 million question. And I'll start with you, Representative Summers. Why are we still at the 46th level of ranking? Why are we tolerating that status? Dr. Box, Dr. Caine, Dr. Guerra-Reyes, why is this not moving? Why are we not changing these statistics? And what are you facing, Representative Summers?
Well, basically, we need money. Basically, we need money, and we need to move the mindset of the men holding the money. And you hear me say the men holding the money. I don't know why they don't realize if we're happy, that makes them happier. They have not figured that out yet. And a lot of things is just not being able to get them funded. And we need to also, like I've said more than once, we also need to empower those community organizations to help on the grassroots level, teaching people those things that we think that they need to know. That's gonna, money is gonna be my biggest thing, but also empowering community organizations to help.
And I would say that there has been, throughout the United States, an inability to accurately determine what the maternal mortality is in a state until the CDC more recently started working with states like Indiana and other states that developed a maternal mortality review committee. The statistics you're talking about were quoted in a USA Today article based on what we call NVSS, National Vital Statistics System records. And that is where basically a death certificate has a checkbox and somebody checks that the patient was pregnant either within the past 42 days or at the time of the death. And what we found when we went back and reviewed all those for 2018 was that there were 23 women that were checked as being pregnant when they died or in the 42 days before, and they were not even pregnant. They had not been pregnant for a long time. On the reverse side of that is when we went back and we said everybody who died between the ages of 10 and 60, we took their death certificates and we crossed it with all of our delivery records, all of our birth certificates. We found an additional 20-some women. So the way that we have been developing and applying maternal mortality statistics and rankings has been very, very off in the United States. And if you talk to any state that does maternal mortality review committees, they will tell you until we have all our states or the bulk of them reviewing it the way Indiana did it this past year for 2018, we will not be able to compare state to state. But we did get very good statistics. And we know that in 2018, we lost 63 mamas, either during their pregnancy or in that first year after their delivery. And we do know that the pregnancy deaths in women who were Caucasian, not Hispanic, were 86 deaths per 100,000. We do know that there were Black women that were non-Hispanic. The deaths were 103 per 100,000. So about 17% higher in the state of Indiana for that 1 year. And our Latinx population was 25 per 100,000. So what we need to do is look at those recommendations, Representative Summers, that we came out with. And we broke those down into, we recommend this for the legislature, we recommend this for the hospital systems, we recommend this for the providers, we recommend this for the community, and for the family level. They were all broken down that way so that we can all become a part of this solution together and address that. Now, going forward in the coming years, as we do this, we'll always be able to compare 2018 in Indiana to the next year we do that cohort for 2019, to the next year we do 2020. But realistically, until we get more data that is accurately represented from states, knowing where we truly fall is almost impossible.
We are 1 minute to the conclusion. I'd like to really thank every one of you. This was exciting and informative to me, and I hope to our participants. I'd like to just conclude with this quote and then turn it to Rima. Each of you are women urging change. So here's the quote. This is Angela Davis. I will no longer accept the change. Am I going to get this right? I will no longer accept that I cannot change things. I will change the things that I no longer accept. And that is what we're about. Women for Change is about change. Each of you have spoken of the power of change and what we can do in various levels, and I thank you. Rima, it's all yours.
Thank you, thank you, thank you. Thank you, Dr. Box. Thank you, Dr. Caine. Thank you, Dr. Lucia Guerra-Reyes. And thank you, Representative Vanessa Summers. And thank you to my good friend, Dr. Velda Miller. I also like to thank our partner organizations, Indiana Minority Health Coalition, Not One More Project, the National Coalition of 100 Black Women, Indianapolis Chapter, Birth, Equity, and Justice, so St. Joe's County, and Indiana Institute for Working Families. As my friend and my restaurant buddy, Representative Vanessa Summers, said, this change cannot happen without your support. If you got something from today's program, if you learned something, if you appreciate it, please consider making a donation today. Nationally, I'd like to share only 1.6% of all national giving goes to organizations that serve women and girls. Please make that change and make a donation today. Thank you to all the participants for your engagement. Thank you to all of those that spent this evening from Allen County and St. Joe's County, Vanderburgh County, and everywhere in between. I really appreciate it. A great thank you to the Board of Women for Change for supporting, to our change makers. And finally, if anybody's acquainted with Women for Change and our work, nothing happens without our Director of Education and Advocacy, Haley Brewer. Thank you, Haley, and thank you to Noelle Snyder, my other colleague. Thank you all. Great things happen when women come together. You will be sent 2 surveys. Please fill those out and return them. One is a general survey, one is around pregnancy in the state of Indiana. Sign up for our newsletter so you don't miss out on a great Women for Change program, because all of our programs are great, obviously. Please, if you follow social media, if you're on social media, follow our work, and we have great programs that are coming up. Please attend. Thank you to Senator Brewer for also attending again this evening. Thank you all. Have a great weekend. Be safe and get your COVID-19 vaccine. Good night.
Rima, can I add one thing? It's not only around the state, but I saw a friend who logged on from Boston. So we're all over. Thank you again.
Thank you.
Thank you.
Good night.
Good night.
Bye.